Hi, my name is Viviana Huarco. I am going to about the intravenous iron in patients undergoing maintenance hemodialysis. Definition: iron infusion is a procedure in which iron is delivered to your body intravenously, meaning into a vein through a needle. This method of delivering medication or supplementation is also known as an intravenous infusion.
Hi, meet John. He's been under a lot of stress that's causing him fatigue, headaches, and an ongoing cold he can't shake. John has been taking vitamin and mineral supplements to make himself feel better, but it's not working. Luckily, Z-Med Clinic has a solution that does. IV infusion therapy. Slow infusion of nutrients and compounds that are infused directly into the bloodstream to bypass the nutrient-depleting effects of the digestive system. This way, patients receive nutrients at a significantly higher level of concentration than possible with oral medication. Z-Med Clinic provided John with IV infusions that specifically matched his medical condition and symptoms. And now, John's feeling energetic and fabulous again. IV infusions work for a large number and variety of medical conditions, from fatigue to chronic medical conditions. It can help anyone, young or old, and is popular with athletes. Whatever your medical condition is, visit zmedclinic.com or call us on 281-292-3030.
Application in medicine. Iron deficiency is one of the most common nutritional deficiencies affecting up to 2 billion people worldwide. Iron deficiency commonly occurs in patients suffering chronic infection. Intravenous iron infusions are used to treat patients with iron deficiency, anemia, and chronic kidney disease. Iron infusions are administered to patients who cannot use oral supplementation to treat their deficiency, or if oral treatment has proved ineffective.
Four and a half years ago, Kidney Research UK and a group of UK healthcare professionals began a clinical trial to discover the best amount of iron needed by patients receiving hemodialysis treatment. So how much iron should patients have? Could it be harmful? And how does it affect wider health? In 2013, the pivotal study, as it was called, set out to answer these and many more questions. The pivotal study compared two clinical approaches to giving iron. Patients either received higher doses of iron or lower doses of iron. And now we have the results.
We can see that giving higher doses of iron is better for patients than low doses. There were significantly fewer cardiovascular problems and no increased infections with the higher dose. We found we were able to reduce the required dose of erythropoietin, or EPO. Doctors do not like using high doses of EPO and prefer giving more iron, because other clinical trials have shown higher doses of EPO can be associated with an increased risk of cardiovascular events such as strokes. The pivotal trial provides reassurance that this is a good approach.
Also, patients in the higher dose group required fewer blood transfusions. This is really positive news for patients, as this reduces the risk of developing antibodies which can affect a patient having a successful transplant. Anything we can do to improve the lives of patients who have hemodialysis is so exciting. There's still a lot to learn from the pivotal study, as the staff and patients involved have given the researchers so much information. So watch this space for new updates in the future. We are so proud of the 2,141 patients that took part in the pivotal study. They gave their time and medical information so researchers could learn from real patients' real experiences. Thank you to everybody that took part, the patients, Kidney Research UK and their supporters, and all of the 50 hospital trusts that supported us. You've all made a real difference to hemodialysis patients now and in the future. Thank you.
Pros and cons. Pros. Intravenous iron is a cost-effective treatment because it reduces the required dosages of erythropoiesis-stimulating agents. Intravenous iron is safe and well tolerated and therefore represents a good choice for the treatment and prevention of iron deficiency anemia. Cons. The main problem of using intravenous iron is to cause hypersensitivity in the patient. If the administration of intravenous iron is not adequate, it can cause local pain.
Namaskar, I am Dr. K.K. Agarwal, President Heartcare Foundation of India and Group Editor-in-Chief, MedTalks. Should all patients of CKD be given iron? Remember that most patients of CKD are on erythropoiesis stimulating agents. They are costly, but many of them actually may be having an iron deficiency anemia and may respond to IV iron. Always get two tests done, the serum ferritin and the transferrin saturation, which is called TSAT. If the patient has a transferrin saturation of less than 20% with a ferritin level of less than 100, it's an absolute iron deficiency and IV iron needs to be given. If the patient has transferrin saturation of less than 30% and a ferritin level of less than 500, look for hemoglobin. And if the hemoglobin is less than 13 in men and less than 12 in women, give IV iron in such cases. And if the values are between 20 to 30 and if the values are between 100 to 500 of ferritin, you may take your clinical judgment. In such cases, even in such cases, giving IV iron helps. Remember, if the transferrin saturation is more than 30% or the ferritin is more than 500, no IV iron to be given. To a simple calculation is transferrin saturation less than 30 and a serum ferritin less than 500, you may consider iron replacement in such cases. Therefore, when you manage a patient with kidney disease, CKD, end-stage renal disease, and if the patient is on erythropoiesis stimulating agent, also look for, should I give IV iron and reduce the dose of erythropoiesis stimulating agent. Thank you.
Issue applied in Ecuador. Chronic kidney disease can be prevented and treated. It is necessary to intervention of a team of specialized doctors. Its prevalence increases with age and identifiable. Causes more common are diabetes and high blood pressure. The new concept definition and classification, or ERC, is therefore operational goal to prevent, detect and manage this disease and your risk factors.
I'm Dr. Manoharan, consultant nephrologist working in Columbia Hospital. Yes, sometimes we transfuse blood to these patients on an hemodialysis at the initial stage when the hemoglobin is very low, which cannot be brought up by whatever the EPO which is available in the market. And if the patient is a compliant who follows regularly with the nephrologist, their hemoglobin can be maintained even from the CKD stage 1 or 3 or 4 too. I think once they start on EPO, their hemoglobin can be maintained, and once they go on dialysis, it can be maintained with the drugs. But some patients who do not follow, their hemoglobin will be pretty low when on initiation of dialysis. That moment of time, definitely they require a blood transfusion to bring up the hemoglobin immediately, and then later on to start them on erythropoietin. Normally available in the market is erythropoietin as well as the darbepoetin, which is little long acting compared to erythropoietin, which is short acting, and both have a same advantage and disadvantage where it has an improving the hemoglobin. Other causes of anemia in dialysis is basically iron deficiency. People who are having a kidney failure do not really intake is very poor, and their absorption of iron is very low. So hence we have to correct that iron before even to start with erythropoietin or the darbepoetin to act on that. Then only the hemoglobin can be maintained, and hemoglobin normally maintained between around 11 to 12 on these patients, because more than 12 again it can cause an hypertension and increased morbidity. So we cannot maintain them as a normal population. To some extent they will get a good quality of life to maintain hemoglobin. And other causes like vitamin B12 have to be ruled out, and if they have any infection in their body, the EPO will not respond in them. So hence we have to rule out some infections and treat them properly at the initial stage, and then take them forward on with erythropoietin.
Conclusion. Among patients undergoing hemodialysis, a high-dose intravenous iron regimen administered proactively was superior to a low-dose regimen administered reactively and resulted in lower doses of erythropoiesis, stimulating aging when administered.